long time, and that is the vasculopathy. The vasculopathy is the root cause of etiological factors of this series of obstetrical problems from first trimester up to the third trimester. You will throw light on this, and you will throw light on how to early detect these abnormalities through imaging technology, which is a very popular topic nowadays. I had the opportunity to hear him long before he talked on missed abortion. I still remember. It was very, very impressive, and I still follow his, the line of treatment he advocated. And not only me, most of you follow. So we are here for a very brilliant speech. Thank you very much. Please.
The oration. As usual, I will start with a prayer. May I become at all times a ship for those with oceans to cross, a sanctuary for those in danger, a lamp for those without light, and a servant of all in need. I present the 62nd oration of my life. I feel very humble. As time rolls by in this 1 hour which has been given to me, you will realize why I say so. This a part of the country, like quite a few others, but especially Northeast, has been very kind to me. I can remember nearly all of you by names. And that is the love and affection which you people have showered on me. This oration will not get over with this session. You will be able to follow it up afterwards. The recording will be available on my YouTube channel, which is now, the smart lady here said 50,000, is now more than 60,000 views, of obstetricians and gynecologists. It is for OBGYN people. You can read the blog of this, and you can even mail your queries to me on this email ID. I will 100% reply. Usually there is a convention that after an oration, no questions are asked. And I am sure it may be followed here as well. But then you can ask me questions and I will answer on my email. To be conferred upon Dr. R.K. Das Memorial Oration is a big thing for me. Coming from this part of the country. And when I was listening to what this great man in those resource crunch days had achieved, I felt overwhelmed. And by conferring this honor on me, you have honored the human spirit. That man, you are giving today the highest honor of the conference. It makes me all the more humble. Mr. Chairman, sirs, in the days of Google, there is nothing remaining where you speak and they don't know. They can go and find it. And that is where my responsibility becomes larger. My first oration I was given by Rajkot Society, I had refused for 3 years, long back. That is because I feel, and I felt that time and I am still feeling, that orations should not be copy-pasted from books and journals. The person, the orator, the faculty should have worked on that field for decades together, then should have the courage to stand and give an oration. Should have one's original work. Should have potentials to change your clinical practice. Then only come and touch life. It should be able to transform your clinical practice. Then only come and give an oration. Lest there are many guest speakers. And therefore I selected the topic. I need a water bottle. Therefore I selected the topic obstetric vasculopathies, co-vadis. I don't give orations or lectures. I give a performance. Because I am a teacher. I am a teacher by choice. I decided to be a teacher in first MBBS when I found that people who are teachers are teaching rotten. I can't understand anything. Therefore, I decided I will become a teacher. And whatever it takes to see that this knowledge sinks into your grey cells, this knowledge sinks into your grey cells, I will do. And therefore, I don't give lectures, I don't give orations, I give a presentation. So keep watching there and just listen to me. I am no longer worth watching, so don't watch me. See these things. Obstetric vasculopathies are very mischievous, like her. But after this oration, we will have reasonably tamed her mischief. What are obstetric vasculopathies? As Dr. Datta sir has said, all those clinical conditions that have a placental vascular origin are called obstetric vasculopathies. Interestingly, all of them have a common immunological basis. It includes early onset preeclampsia, preeclampsia which appears before 32 weeks, recurrent missed abortions and late first trimester, early second trimester. Not all missed abortions, not all abortions. Recurrent stillbirths. IUGR of placental origin, not of the fetal origin. Accidental hemorrhage. And some people add chorea gravidarum to this. This is a long journey, where focused dedication and commitment. One of my teachers said, Pankaj, go deep in one area. Go deep, go deep. And it touched my life. And we went on this. This is a journey of more than 3 decades. We presented the first paper of our work titled Preeclampsia Remote from Term in 30 AICOG. We are on the threshold of holding the 66th AICOG. So this is a work of 36 years which I am presenting to you. The most important conclusion in that paper was type of preeclampsia remote from term is a distinct entity. It behaves badly and has a stormy outcome. And the full text of this paper was subsequently published in 1988, which made us encouraged to read, to go deeper. We went on following up these cases. In India, how difficult it is to follow up, you know. But whatever we could follow up, we found that 59.8% develop preeclampsia in next pregnancy. So it doesn't stop with one pregnancy. 24.4% developed severe preeclampsia. Consistently a poor fetal outcome. High missed abortions and late first trimester and second trimester. And high IUGR in subsequent pregnancies. That made the picture clear that the challenge is severe. And whenever the challenge is severe, you have to go deep inside. And as Einstein said, if you have simplistic solutions to complicated problems, you are telling lies. There are no simplistic solutions. And when we tried to find out going deep, our mouth remained open like this. We were simply overawed as to what Ma is doing there. What is she doing there? And that is where the question came, what produces obstetric vasculopathies? I'll come with 2023 September thinking, updated up to that. I have covered this extensively in these two books of mine. I have not come here to sell my books. One of this book is published from England and it is sold. The price is 6,920 rupees. It is not available in India, being sold abroad. I am telling them to come with the Indian edition. They said it's doing lots of business there. We are not selling in India. Whatever it is, that your book becomes their property of the publishers. But how to buy it, it is available on my website. And that is where I introduce you to the concept of uterine glands, uterine milk, and obstetric disasters. The placental development starts at the time of implantation, immediately. On day 7th of post-conception. And by day 11, the conceptus is embedded within the superficial endometrium. You know this. But this environment is very tight. Those who are doing exercises regularly like me, they know what it means to have a tight grip. This is a very tight and completely autonomous environment which preserves itself on its own because organogenesis is taking place. The mother has no control over this pregnancy at that stage. Not a single drop of nutrient from the mother, what she eats goes there. Please understand this. I am going to shock you still further. The atmosphere there is hypoxic and nutrition is through endometrial glands. The mother survives in a fully aerobic oxygenated environment and that small atmosphere of few millimeters or few centimeters survives completely without oxygen. And if one atom of oxygen by mistake passes through, the conceptus dies. The conceptus becomes malformed. Understand this. ये क्या चित्रकारी है? Here she appears. That omnipotent, omniscient force, completely paradoxical in the same woman. Fetal trophoblasts, they signal the uterine glands and ask for the secretion of growth factors, not growth hormone, growth factors. Immunologically very, very pulsatile atoms and atoms and molecules. They are required for maintenance of pregnancy. And the conceptus and the ma, they talk. It is called cross-talk. If that talk fails, there is an abortion. If the mother is not able to listen to, or the mother is not able to hear, not through her ears, but through her endometrial glands, the conceptus is aborted. The secretions of uterine gland, also called as uterine milk, appear to be the most important source of nutrient for the fetus during the period of organogenesis. This is all happening around you. Have you ever wondered that in the first trimester of pregnancy, under the effect of HCG, the mother vomits and vomits and vomits. But the obstetricians are just not worried because nothing is affecting the fetus. It doesn't go sick. The fetus just doesn't require the mother's nutrition. It will be after 12 weeks that it will be required. And by 10 to 12 weeks, the loosening of this tight autonomous phase begins. This is the phase of second wave of trophoblastic. This is where the mischief takes place. This is the second wave of trophob. First wave was for anchoring. Latest by mid-trimester, there is complete remodeling of the spiral arterioles, reducing the vascular resistance. Clinical effect, the blood pressure goes down. But then that is not a rule. Everything has exceptions in Mother Nature. Suppose this doesn't happen. But if there is, suppose, incomplete remodeling of the spiral arteries, there will be a malperfusion of the placenta, incomplete second wave results, incompetent and incomplete both. Incomplete and incompetent second wave results in most obstetric vasculopathies, including preeclampsia. So this is the second wave of trophoblastic invasion complete. And this is not complete. Now I am taking you further deep inside so that you understand. Friends, I am going to make you sit in this segment of the uterine arteriole. I am taking you there and you sit there. You can sleep there as that lady in green is sleeping. I have no problems. But then, this is what happens there. Because of a genetic predisposition, a very amorphous genetic predisposition, the woman is susceptible to vasospasm, not severe, some forms of vasospasm. And that is the time when the HDL, LDL and VLDL we are circulating. HDL because of its higher density, because of its larger atomic particle size, that cannot sink. But the LDL and VLDL sink between the two vessels. I have taken you in that area, and in that area into the wall, and into the wall between the two cells, between the two maternal endometrial cells and the spiral arteriole cells. And this is where the sinking is taking place. Now, what is the problem? But this becomes the seat of release of free oxygen radicals, leading to denaturation of lipids. Not the HDL, because HDL has not sunk. What we know, very interesting now. What we know that the basic pathology in vasculopathy is vasospasm, and this we have been taught. Gogoi sir must have taught this, I am sure. Such an old thinking. But now what we should know is, it is not the vasospasm, but the reperfusion damage that invites vasculopathy. See this. What do you see here? It is not a wall. It is a frozen wave, in front of which a lady is standing and posing. This is where the vasospasm has occurred. But now what will happen? When the snow thaws, there is reperfusion, and see what happens to the lady. She is thrown into the circulation. This denatured lipid, LDL and VLDL, as soon as the vasospasm is relieved, they get flushed into the circulation. They start moving. And wherever they go, they produce a vasospasm. Now what happens? The maternal system senses that there is a vasospasm, which is a result of the reperfusion, and she has to maintain the blood pressure. Because there is a vasospasm, there is a poverty of blood supply, she raises her blood pressure, and you label it as preeclampsia. This is the immunological basis. I am now taking you to one more new thinking. One of the group which has worked most in that is St. George's University at London. And what is it? It is happening around you. Like this gentleman, but we are oblivious. This gentleman is watching the mobile, not understanding that you have to stop. So many things are happening around you, and you don't know. You have left with the question, "Haan hota hai?" Hota hai. There is the answer there. The focus in these cases have shifted from the placenta to the maternal cardiovascular system. In many mothers, it is not the fetoplacental unit that is at fault. It is a maternal cardiovascular system which is at fault. In an already compromised cardiovascular function before pregnancy, the pregnancy adds to a heavy load, resulting in a series of adverse malformations. I will prove this. I will give you evidence. In a mother with suboptimal cardiovascular capacity, the circulation is already compromised and there is inadequate perfusion through her body. Now, what is the proof thereof? Both conditions happen with advanced maternal age. Preeclampsia and cardiovascular disease. Both conditions are associated with obesity. We know in both of them these things happen. Smoking mothers, same thing happen. In both of them these things happen. In autoimmune conditions, including systemic lupus and antiphospholipid, both these conditions happen. There is a small division there. Premature ovarian failure, both these condition happens where ovarian donation has been done. Diabetes, both these conditions happen, and cardiovascular conditions. One more situation. The mother's cardiovascular condition is fine, but the demand of the growing fetus is very high. And we see preeclampsia in them, like multiple pregnancy, fetal macrosemia, gestational diabetes, post-nat pregnancies, excessive weight gain in the mother, requirement is more, therefore the mother is not able to cope up. I'll give you one more proof. What is common in them? They all won gold medals in the recently concluded Asian Games. Okay? Sir, you agree? That late gentleman in dark who was yawning? Yeah? They all won gold medals, sir. That handsome gentleman behind Indrani. Okay, just behind, he is also looking behind. No problem, sir. Now see this. See how our mother is at a disadvantage. In one study it was found that Olympic athletes register an increase of 25% in their left ventricular mass over a long period of training, vigorous training, you know this, of 24 months. 25% they are able to increase and their coaches are happy. Whereas your mother, whom you are treating for antenatal care, is expected to raise her capacity by 40% in 9 months. 40%, and if she is not able to, preeclampsia results. The cardiovascular system is not able to cope. If her cardiovascular is inherently compromised, she will not be able to raise it, and the result is what you call as preeclampsia. This is happening around you. Just keep thinking. I am going to make you think still further. Is birth a cure to preeclampsia? It should be. If preeclampsia is occurring because of pregnancy, when the baby is born, the process is reversed, blood pressure should be normal. Does it really happen? Immediately and for a long time? No, it doesn't. We all know, not in all cases. Why? In many of these cases, the process of hypertension persists over a long time. The reason is, these are the pregnant mothers who are already having a compromised cardiovascular system. Next time a mother after 3 months comes to you with had preeclampsia in a pregnancy, 3 months postpartum and registers a higher blood pressure, please seek a physician's opinion, including study of the QT wave. I am not going into QT wave at all. These are different areas, but that the physician is supposed to do. So even after delivery and puerperium, this suboptimal cardiovascular functioning continues, and she continues to register hypertension. Have you ever thought why after 3 months also she is coming with more blood pressure? It is, the placenta is gone, but sir, it was not the placenta. I had so many cases shown by Panchananda and others. It was not that which was bleeding, something else was bleeding. And this paper, these effects can last up to 30 years after a pregnancy. Microvascular endothelial dysfunction effects can persist up to 30 years after pregnancy, because the problem is here. It is not in her uterus. So it seems now that there are many causes which are manifesting as one condition, preeclampsia. Friends, I fully understand you doing this. This is a theoretical lecture. This part, up till this part is theoretical. I am nearly halfway. It is time to put theory into practice. And for that, don't worry. I knew that you are going to go to sleep. And therefore, I am going to wake you up now. Venit licture means this entire music is La Fortuna. Some of you must be knowing it. I think Saswati knows it. It is, the whole thing is, the words are, means leaving everything to fate. Therefore I brought it. We don't now leave everything to fate. It's her problem and her fate that she developed preeclampsia. No, we go practically inside and help her, try to help her. Friends, two situations. Two mothers walk into one after the other your clinic. One is a primary gravida, first time pregnant. Another one is pregnant again. Can you predict in them if they are having preeclampsia or they are going to develop preeclampsia? One which is a multi, you can dig deep inside. First fetal demise at 28 to 30 weeks. Second was a spontaneous abortion at 11 weeks. FHs were seen and then lost, so missed abortion. Third was a full-term severe birth, severe PIH with IUGR. Fourth was IUGR that survived. Is she at a risk of developing preeclampsia? Indrani? Yes, she is. If not she, who? She has so many manifestations of obstetric vasculopathies. That villain is not going away. You have to just dig a little below, as these archaeologists are doing, and you will be able to make out. But the challenging situation comes now, and that is where teachers are required to come on the podium. No history of hypertension, no history of chronic disease, kidney disease, no history of autoimmune disease, type 1 or type 2 diabetes, chronic, none of these, no chronic hypertension. Is she at a risk of developing preeclampsia? And you face this in your clinical practice. Well, that is where you have got many recommendations throughout the world, but we have to be local. I am coming to this. The problem with the recommendation based on biomarkers for us is, by 11 to 14 weeks, all USGs and biomarkers are paid by NHS or by insurance agencies. And everything is done on the same premise. But 90% of my mothers don't get any of these facilities. They have to go get these tests done. So for our setup, and that is what I discussed with them also, not that I am debating with them, extra payment by mothers, logistic problems. So can we use 11 to 14 weeks scan to make a more competent prediction of preeclampsia? Yes, we can. Without biomarkers. And I will be presenting you proof. Science is proof, not because I am saying. You can challenge me also, nothing wrong. And many of these present things I am coming here is because of the series of challenges I faced. At 11 to 12 weeks on a regular follow-up, she is normotensive. I am talking of the first primary gravida. And pregnancy is proceeding uneventfully, everything is fine. NT is within normal limits, nasal bone is seen. This is a typical picture you all, Ashish Da, Apurva, you project. And you encourage us. Or my patients who come from Assam, I send to you people and you say, Pankaj, you have done proper ultrasound. Thank you, sir. But at the same time, we also focus on the uterine artery. Okay. This is a typical expected picture. And you have seen so many reports, so many pictures. Have you tried to go deep inside and see? See the PI. Is it more than 1.7? 1.7 is based on data. Measure her diastolic notch depth. What I mean by it, I'll tell you. If the diastolic notch is absent, either it is present or absent, if it is present, measure the depth. I am telling you the depth, about the depth. But if the diastolic notch is absent, see the PI. If it is less than 1, then this is a low-risk subject, no obstetric performance, nothing, no problem. Tell her to go home and sleep. Nothing is, no obstetric vasculopathy is going to happen. A very competent second wave of trophoblastic invasion is taken and she is fine. But you will not get more than 6% cases. All this is published in international journal. You can see here. What is this measurement of diastolic notch I am telling you? These are the dimensions we take. And the first paper on this came from Japan, 2012. Then much more studies came from India. The positive likelihood ratios of NDI and PI for predicting preeclampsia showed that in the second trimester, these could assist to find high-risk women for preeclampsia. In this superficial one, the NDI was 0.1 to 1, and in the deep one, it was 0.371. That means, and how do you measure? You put the dots at these 2 points here, 1, 2, calculator is there. This is very simple. It is there in your USG machine. And then once you pick up that this NDI is more than 0.5, this is a high risk case. We reinforce this just as NHS is doing USG plus biomarkers, and we first used NDI more than 0.55, highly significant, a very good test on data analysis. We also reinforced it. With what did we reinforce? NDI 0.55 and PI more than 1.7, and it was found that statistically significant, though its positive predictive value was average, specificity was excellent, negative predictivity was excellent. That means if it is not crossing this, she will not develop preeclampsia. And this was published in where Saswati gave a lecture in Bangalore a couple of months before their conference, their journal, this was published. We start aspirin at 12 to 14 weeks if PI, even in one of the uterines, is more than 1.7. And NDI more than 0.55 even in one of the uterines. We stretch it a little further. Because I do regular exercises, I love to stretch, and we all know, those who are doing regular exercises, that stretching is a must. We stretch the data also. Stretching color Doppler still further to discontinue preventive measures in low-risk subjects. You started it in first trimester, she comes to you in second trimester, can we stop the aspirin? Are we over-giving it? Or sometimes heparin we start. There are protocols for that. Can we stop? Normally we continue till 36. अरे कौन करेगा? कुछ हो गया तो कुछ हो गया. Like this. जो डर गया, समझो मर गया. ये मैं नहीं कह गया, वो गब्बर सिंह कह गया. He died long back. डरो नहीं. See the data. Fall back upon your teachers. Fall back upon their data, not their teachers. There are two interesting game changers in mid-trimester. And what are they? If PI dropped by more than half, previously PI was 1.8, in the second visit it is less than 0.9. This is a low risk case. On what basis I am telling? This is based on 167, all prospective data, all published data. And there also we brought in a reinforcement. If notch disappears, notch may not disappear. But if the notch disappears and PI drops by more than half, 100% this is a low risk case. Stop that aspirin, stop that heparin. Have the courage. Nearly 63% of our aspirins we are able to stop. So what is the message? Uterine Doppler, artery Doppler is very good to predict preeclampsia and other obstetric vasculopathies. A quick revision. In first trimester, PI more than 1.7 plus NDI more than 0.55. This is a high risk case. Irrespective of parity, she might be a primary, multi, doesn't matter. This will come on my YouTube channel. I will inform you also. And if PI is more than 1.7, NDI more than 0.55, no obstetric performance, still start aspirin. Because till now at 14 weeks aspirin will act. If PI is less than 1 and absent diastolic notch in first trimester, this is a low risk subject. Stop aspirin heparin. By their policy, the Fetal Medicine Foundation was able to prevent these many cases. We have comparable figures to reduce the size of the oration. I have not brought the data, but this policy has been proved to be effective and reduces significant number of patients of preeclampsia on basis of this prediction. Now we come to the last part. Aspirin we give in a dose of 1.2 milligram per kilogram per day, which comes to around 75 milligrams per day. In Western countries, they are given 150 milligrams per day, and therefore, in nearly all conferences where I take up this, I am asked this question frequently. Sir, what dose? How much aspirin? October 2023 reference. Time to reconsider our recommendation. That is what the authors asked. And the American College of ONG is giving around 80 milligrams, so somewhere around 75. World Health Organization recommends 75 milligrams. And the Royal College of Obstetrics and Gynecologists 150 milligrams. Picture is muddy. And whenever the picture is muddy, what should we do? Keep doing what you are doing. Keep doing what you are doing. Please wait for the final answer. It is at night. It is useless to start after 16 weeks. Absolutely useless. I see many prescriptions started after 16 weeks. It is useless. Only the pharma company has benefited or that store has benefited. We also give preconception 3 months in high-risk cases who had bad history. At least 3 months before we start, 75 milligrams or 1.2 milligram per kilogram. Not for all subjects. This is not aspirin, this is not iron calcium. You are over-treating. Best, find out if she is susceptible to that. As a teacher, I will never agree to this over-treatment. Over to the future. This is present. We saw the past. Over to the future. I am looking at the days where the quarks will come in. I am not talking of quacks. Those of you, I am sure, sitting behind know what are quarks. They are subatomic particles. Even, yes, that gentleman has nodded. Even lesser than the electrons and protons. And they are all full here. Many times we say that this is an empty space. No, it isn't. Even the space upstairs is not empty. It is very full, very tight. And I am seeing the days where under the effect of using these quarks, we scientists will be able to clean up the genetics involved and not allow even the first vasospasm to occur, however minimal it is, and make maternal and fetal crosstalk successful, then preeclampsia will be bye-bye. This is the future of preeclampsia and obstetric vasculopathies. So friends, we have to accept that preeclampsia is a dynamic challenge. It continuously moves and you have to run to be at the same place. There are amazing futures in medicine for this. And future is yours. All my friends sitting there, future is yours. Take it up. This is for you. So friends, it is simply a great honor. I have worked for nearly, since Dada told me, 1.5 months on this presentation. Every day, including Sundays, so as to finally give you this final message.
I'm happy that you have tried to, translate those effects in the very, root level, in the very vascular level, to the imaging level. You see, it is really fantastic. And I'm sure this, the Doppler sonography will go a long way in predicting this. Thank you very much for coming all the way from Ahmedabad and enlightening us this evening. Thank you very much.
And finally, Dr. Desai, wonderful speech. I'm indeed very grateful for this wonderful speech that you have given in the honor of my father. And I wish the Neoscon Society a very big future.
Now I would request Professor Shubhra Das ma'am to felicitate Dr. Pankaj Desai sir. Thank you, ma'am. Now I would request the Professor Shubhra Das ma'am and the chairpersons to jointly felicitate Dr. Pankaj Desai sir.
Clap for him. I know you are hungry. That was wonderful conference he has organized. Clap for him.